Morning and good evening to all the friends, my teachers, the panelists, delegates, the discussants, and the friends from all across the world. Welcome to ACNS YNS Webinar series. And welcome you all on behalf of ACNS. We conduct this webinar on every second and fourth Sunday for sole purpose of training and education of especially young neurosurgeons. And we have a format wherein we invite a guest expert faculty and young neurosurgeons also. So there'll be interactions with the expert faculties. So for that, today we have one of the eminent and scholar and a neurosurgeon who need no introduction, Professor Atul Goyal from Lilavati Hospital, and Dr. Ahmed Al-Hamari as our young neurosurgeon who will be presenting on tuberculous meningioma from Saudi Arabia. Professor Yoko Kato, who is the president of ACNS, is our chief patron. As a chairperson for today's session, we have Professor Tsuyoshi Zumo, who is the associate professor at the Department of Neurosurgery, Nagasaki University Graduate School of Biomedical Science, Japan. And the two discussants for today is Professor Alexander Wozniak, who is the president of Ukrainian Society of Neurosurgery, and Professor Fawad Firzat, who is the president of Neurosurgical Society of Afghanistan. And along with me, we have Dr. Hira, Dr. Sharon, and Dr. Alberto as a co-moderator. And for today's session, we have Dr. Chen and Dr. Liu Boon to help me for the moderation today. So it is a fantastic session planned today. So before we start, I would request Professor Yoko Kato to say a few words and then we'll start the webinar. You're muted, Professor. You'll have to unmute yourself.
So thank you, Sachin. So I think today's webinar is one of the best webinars. I think it was my good friend and also teacher is Atul Goyal. So we'll talk about his very favorite talk. And also the Amita Shah, the best student of him, is attending, and maybe she can, yes, so maybe she can make some comment. I don't know. So, and also the young doctor from Saudi Arabia, I'm very much looking forward. And also Alexander and Professor Izumo, and also soon I think Fawad will join us. And also the E. Thank you very much for joining. So we can start. Thank you very much.
So before we start, may I take permission from the chairperson today, Dr. Izumo. Can we start, Professor, or you want to say a few words before we start to encourage the young neurosurgeon?
Oh, yeah. Thank you. Thank you, Sachin. I'm Izumo from Nagasaki University. It's my honor to take chair this time. And I'm very looking forward to hear the lecture, excellent speaker, Atul Goyal, and young neurosurgeon, Al-Amari. So everybody are looking forward to hear the excellent lecture this time. Thank you.
Thank you. Thank you, Professor. So just a formality of the introduction. Otherwise, as I said, Professor Goyal is a neurosurgeon who does not need any introduction. And he's an inspiration for all the young neurosurgeons all across the world. And he's inspired all of us with his philosophy, with his off-track thinking, and then showing the world that his track is the right track. But just to complete the formality, Professor is the head of the Department of Neurosurgery at Lilavati Hospital and Research Center. He's also consultant neurosurgeon, Bombay Hospital and Research Center and Tata Memorial Hospital, and also professor neurosurgery at RN Cooper Hospital and Medical College. He's our past president of Neurosurgical Society of India. May I request Professor Atul Goyal to please start his lecture. Over to you.
Okay. Thank you, Sachin, and thank you for all that introduction. And before I start, I must say that Yoko Kato is my absolute idol of neurosurgery in the world. What she has done for the neurosurgical community of the world, for the relatively not very prosperous regions of the world, for women in neurosurgery, for young neurosurgeon in the world. I think this contribution of Dr. Yoko Kato will be remembered for a very long time. And it is my great pleasure and honor to know her and to know that she is continuing to very actively promote this neurosurgical education throughout the world. And I see several young neurosurgeons in the audience. So my talk will be dedicated mainly, as has been decided by Sachin, for young neurosurgeons. And let me begin my slides. Can you see, Sachin, my slides? Yes?
Yes,
Yes.
Professor, we can see it. Yes, sir.
So what I'm going to try to do today is to introduce some new concepts and some new vision in craniovertebral junction and spine surgery, different from what is there in the literature, different from what is discussed as a routine. So first thing that I'm going to talk about or introduce is the issue of central or axial atlantoaxial instability. This issue, as you must know, has never been really discussed in the literature. And if you wish to ask me, this issue has great implications in the treatment of number of pathological things that we see. So let me talk about this issue of central or axial atlantoaxial instability. Another thing that I want to discuss is, and of course you all know that the main issue in spinal neurosurgery is the issue of compression, that compression is the problem and decompression is the treatment. My concept is absolutely clear that compression in the parlance of spine surgery, compression is never a primary issue. Compression is always secondary, compression is always protective, and compression is always reversible. So these three things, it is secondary, it is protective, it is reversible. And on the basis of this concept, I'm going to take you beyond decompression. Decompression, everybody talks of decompression in spine surgery, in particular, in brain surgery also. But I'm going to take you beyond this issue of decompression. And I want to listen to these new concepts which I am proposing before you in a perspective. You think about this. You don't take it as a gospel truth. Don't think beyond what you have to think. Think about it and see if you can get some new ideas. So my concept is that compression is never primary and decompression is never the treatment. So this is a very huge statement that I am making, huge, that don't do decompression. So just enjoy it and just listen to what I have to say and see if you can modify your treatment on the basis of the concepts which I am going to present. Instability is the issue and stabilization is the treatment. This is my key sentence. Now, this is a human body and all our muscles are located at the back of the spine. We are standing human position. All our muscles are located in the extensor compartment, in the back of the neck, in the back of the spine, which help us make us stand and make us run and make us sit. There are no muscles or very, very few muscles in the relationship to the vertebral body and with the relationship of the disc. All our muscles are concentrated on the back. So my concept is this muscle weakness due to disuse, abuse, or misuse or injury is the basis of a number of problems, including craniovertebral junction and in the rest of the spine. Like a bird will never have a problem in the spine because the concentration of muscles is in the wings and shoulders. Similarly, a four-legged animal has concentration of muscles in the legs and shoulders, not so much in the spine like a human body. I wish to introduce another fantastic, probably a revolutionary concept of vertical facetal instability. When we stand, when our muscles become weak, there is a telescoping of the spine. They become vertically unstable. This instability may not be recognizable on radiology. You cannot see on dynamic images any instability or any movement, but this is vertically unstable. And this vertical instability can be a nodal point of generation of a number of diseases of the spinal cord. So let me go from the beginning. Many of the young people in the audience may not know that there was an entity called fixed atlantoaxial dislocation. This atlantoaxial dislocation was of two types, fixed and mobile. For mobile dislocation, fixation was the treatment, and for fixed dislocation, decompression was the treatment. So in the year 2004, actually in the year 2000, we introduced a very fantastic concept, a revolutionary concept, which has completely changed craniovertebral junction surgery, that there is nothing like fixed dislocation. Whenever you see a fixed dislocation, fixed means when you do flexion of the head and extension of the head, odontoid process does not move from its dislocated position. So we said that there is nothing like fixed dislocation. When you see fixed dislocation, it is mobile, it is pathologically mobile and unstable, and it needs stabilization. So in flexion and extension, there is no change in this odontoid process. So the generally recognized and very popular method of treatment in the world was transoral removal of odontoid process or decompression. But open the joint, manipulate the facet, and craniovertebral junction realignment and stabilization as a concept. You see, as a concept, that this does not need decompression. Instability is the issue and stabilization is the treatment, completely change the subject in general. You see, this is inflection and extension. There is no change. So there is a possibility of realignment, stabilization, and there is no need for decompression. So this was the concept we introduced about 20-25 years ago. We said for the first time that basilar invagination is related to listhesis of C1 over C2. This is C1 facet, this is C2 facet, listhesis, like lumbosacral listhesis. So this is an unstable situation like basilar invagination. We said that this needs stabilization and this does not need decompression. So now let me talk about basilar invagination. Basilar invagination is a very disabling and crippling disorder for those who have it. So in the year 2004, for the first time in the literature, we said, we divided basilar invagination into two groups, and we said that this group A is unstable and it does not need decompression, it needs craniovertebral junction realignment. In the year 2004, we said that group B patients have a fixed anomaly, fixed atlantoaxial dislocation, and they need foramen magnum decompression. So this was my concept in the year 2004. And this group, group A, open the joint, distract the facet, and reduce the dislocation. So this is basilar invagination. We said that there is no need for decompression, either from front or from behind. Open the joint, distract the facet, stabilize, and there is a craniovertebral junction realignment. So this is post-operative. You see, this is completely inside. You can actually distract and reduce and realign. More important than realignment is stabilization. So we have got over the years several hundred patients of this kind from all over the place, where we have distracted the facets, fixed the atlantoaxial joint, and reduced basilar invagination. As you can see, there is a huge basilar invagination, reduced and stabilized. There is no decompression. So the concept is these are unstable situations. They need stabilization. My current concept is that even if it is not completely reducible, that is not the issue. Instability is the issue and stabilization is the treatment. So this is another case of basilar invagination. You see, you can realign. There is no need for decompression. They are remarkably unstable. You open the facets, you will find that the whole system is completely mobile and unstable, and stabilization is the treatment. Now I go to another very phenomenal new entity called central or axial atlantoaxial instability. There is no question in my mind that it expands the horizons of craniovertebral junction surgery. And if you read this paper between the lines, you will see that central instability is present in basilar invagination, in Chiari malformation, in syringomyelia, in cervical spinal degeneration, spinal deformities like kyphosis and all, OPLL, and Hirayama disease. So understanding of central instability is absolutely crucial. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common instability of the body, of the spine. And I have no hesitation to say that atlantoaxial instability is the most under-recognized and under-treated clinical entity. So now I want to show you what is central instability. Now I have talked about listhesis of C1 over C2. This is listhesis of C1 over C2. Atlantodental interval is increased. There is neural compression by the odontoid process. Listhesis and instability is the issue, and stabilization is the treatment. There is absolutely no role for decompression. And there is no confusion in the world now about this problem. Now the confusion is in this problem. This is basilar invagination group 2, and the whole world today will do decompression of the craniovertebral junction from behind, foramen and magnum decompression. There is no atlantodental interval disturbance. But if you carefully see, the facet of C1 is behind the facet of C2. This is clearly an unstable situation. This kind of basilar invagination does not need decompression. It needs C1, C2 stabilization. There is no question in my mind that any kind of decompression can be a negative operation and should not be done. Over the years, we have completely abandoned occipital fixation. We have never resort to occipital fixation. Atlantoaxial instability is the problem, and atlantoaxial stabilization is the issue. Now you carefully see another. Now there is no facetal malalignment in this patient. There is no atlantodental interval disturbance in this patient, but presence of Chiari, presence of syringomyelia, presence of assimilation of atlas, presence of platybasia are all indicators, are all secondary to atlantoaxial instability. They indicate the need for atlantoaxial stabilization. And there is no question in my mind that if you do atlantoaxial stabilization, you completely create a revolution in the patient's clinical symptoms and sign, and the person gets a new life after surgery. And radiologically, the syringomyelia reduces in 100% of cases. So this is a new treatment which I wish to propose to you. So when atlantoaxial instability is acute, the problems are different, like pain in the neck, stiffness in the neck. But when atlantoaxial instability is chronic or long-standing, there are several natural reparative things that happen, which include shortening of the neck, torticollis, musculoskeletal problems, bone fusions, clipper file abnormality, C2-3 fusion, assimilation of atlas, platybasia. So there are several musculoskeletal and skeletal issues and neural issues like Chiari and syringomyelia. So chronic or long-standing atlantoaxial instability is the issue. This instability may be for 15 years, for 20 years, maybe for 25 years. Subtle, potential, manifest or potential instability can lead to secondary issues like Chiari, syringomalia, syringobulbia, external syringomyelia, short head, short neck, basilar invagination, kyphoscoliosis, torticollis, bifid C1, C2-3 fusion, and a number of other problems. These are only a small summary which I have given, and I will introduce you to more secondary features of chronic atlantoaxial instability. So when you see a patient with Chiari, there is no question instability is the issue. When you see Chiari with syringomyelia, there is no question atlantoaxial instability is the issue. When you see Chiari with syringomyelia with basilar invagination, so whenever any of these, when you see only bifid C1, it is atlantoaxial instability. When you see only Klippel-Feil abnormality, it is atlantoaxial instability. So the primary issue is atlantoaxial instability, and secondary issues are all these which are listed and many more. They are all secondary, they are all protective, and they are all reversible. So this is a very huge concept, and this concept is here to stay and here to progress in the field of spine. And there is no doubt about it. So let me discuss this concept in further details. So this is a case of Chiari malformation, syringomyelia. There is basilar invagination. So all these basilar invagination, Chiari, syrings, all these things are related to atlantoaxial instability. Primary issue is unstable atlantoaxial joint. These are secondary, these are protective, and these are reversible. So you have to know there is no place for decompression in this situation. You have to do realignment and stabilization. Even when there is no atlantodental interval disturbance, even when there is no facetal malalignment, there are other evidences of atlantoaxial instability like assimilation of atlas, platybasia, Chiari malformation, and all those things. External syringomyelia in this situation, they are indicators. They are indicators of atlantoaxial instability and indicate the need for atlantoaxial stabilization, and also suggest that when the situation is unstable, there is no need for decompression. The need is for stabilization. Decompression in an unstable situation is a negative operation. So this kind of basilar invagination, flat clivus, platybasia, you see the odontoid may be up and all those things. This does not need any form of decompression. This needs stabilization of C1, C2. And this is not an easy operation. It is difficult, but this is the treatment, and this treatment has to be done. So this kind of basilar invagination, the whole world, I have no doubt and hesitation to say till date, the whole world will do foramen magnum decompression for this situation. But my complete conviction and complete understanding is that atlantoaxial instability is the issue, and stabilization is the treatment, and magic is the clinical outcome and radiological outcome. So basilar invagination, now we should try to understand in a different perspective and a format, and we should realize that instability is the cause and stabilization is the treatment for both group A and group B instability. And we have several hundred patients now over the years collected for both group A and group B, where I was myself doing transoral decompression and foramen magnum decompression earlier in my career, 15 years, 20 years ago. But now there is no question that both these entities need stabilization and atlantoaxial stabilization. So basilar invagination, syringomyelia, and Chiari formation are all secondary to atlantoaxial instability. So in the year 2013, we wrote this article, Atlantoaxial instability is the cause of Chiari malformation, and atlantoaxial fixation is the treatment. And there was a huge controversy in the world of neurosurgery that they don't agree and decompression is okay and all those things. But I have a feeling that slowly but surely this concept is now emerging in the field of Chiari malformation. More recently, I wrote this article about our experience with 388 cases. Now my experience is nearly 450 cases with only atlantoaxial stabilization and no decompression. And if you read this article, the clinical results are almost 100% recovery. 100% is absolute magic figure in neurosurgery, which no other treatment paradigm will ever be able to replicate. Chiari malformation is secondary and atlantoaxial instability is the issue. So we have now these kind of cases. There is no atlantodental interval disturbance. This kind of Chiari, you will of course like to do decompression, which is a negative operation. Look at the facets. Even when the facets are in alignment, there is no question. Facets, whether they are in alignment or they are not in alignment, Chiari is an indicator of atlantoaxial instability. Syringomyelia is an indicator. Do fixation and see the magic. And we have got several cases where I have seen the magic in radiology and magic in the clinical outcome. So I have told you that syringomyelia will reduce in 100% of patients if you have done a scan after 1 year. And if you have done a scan after 3 months, it will be reduced in more than 50% or 60% of patients. The size of syringomyelia will reduce. Whether syringomyelia reduces or not, that is not the issue. The patient will remarkably recover in the clinical symptom in the immediate postoperative period in a magical form. So when there is bone malformation or not, whether there is basilar invagination or not, whether Chiari is associated with basilar, whether Chiari is associated with syringomyelia, whether Chiari is associated with other malformations or not, whether other malformations are present in isolation, they all indicate atlantoaxial instability. They all indicate the need for atlantoaxial stabilization. So syrinx will disappear, tonsil will go up, and this kind of thing does not need atlantoaxial, no need for decompression. And many of these things and many other issues are discussed in my articles on the subject, which I wish that you please read them and try to go between the lines and try to understand my concept that instability is the issue, stabilization in all Chiari. I'm not talking of tumors and Chiari or hydrocephalus and Chiari or bifid, lumbar bifid and Chiari. I'm talking of Chiari. And I like to call Chiari as a formation because I find it a protective and I find it that it is not a malformation. Similarly, bone fusions, as I have said, is the son or daughter of the same father, that is atlantoaxial instability. They are protective and they are indicators of atlantoaxial instability, and they need stabilization of atlantoaxial joint. So there is multi-segmental fusion. There is no real compression at the atlantoaxial joint. This patient does not need any corpectomy or any kind of decompression. This patient needs atlantoaxial fixation, and absolutely fantastic clinical result can be expected. Bifid is secondary, bifid is protective, bifid is reversible. And I have discussed this issue in my article where we have said, whenever you see bifid, whether you see any compression or not compression, stabilization is the treatment. Os odontoideum is also the child of the same father, that is atlantoaxial instability. You need to do atlantoaxial stabilization. So when you see atlantoaxial instability, when you see os odontoideum, whether there is movement on dynamic imaging or not, these kind of pseudocysts, these kind of osteophytes are indicators of unstable atlantoaxial joint, and stabilization is the treatment. When you see bifid, when you see multisegmental bone fusions, even when there is no compression, the treatment is one, and treatment is only one, and that treatment is atlantoaxial stabilization. Similarly, syringomyelia, whether it is present with Chiari or not with Chiari, whether with any other bone malformations or any other external musculoskeletal issues, it is always helpful and not harmful There is no need to do direct puncturing of the cyst or sealing of pleural and peritoneal shunts. What you need to do is atlantoaxial stabilization whenever it is indicated. I'm not talking of trauma and syringes, tumors and syringes, or infections and syringes. I'm talking of a regular syringes. So when you see syringomalia, look at the craniovertebral junction and do stabilization, and absolute clinical magic can be expected. Musculoskeletal abnormalities like short neck, short torticollis, and all these things are all secondary. They are all protective, and they are all reversible. You do only atlantoaxial fixation. There is no need for any kind of osteotomy or decompression. And there is no need for any other treatment other than a solid, beautiful fixation if you want to see a beautiful smile on the patient. We also introduce another term called external syringomalia. So water in the spine, whether it is inside the cord or outside the cord, whether it is inside the medulla or outside the medulla, is always secondary and always protective and always an indicator of unstable spinal segment, which is atlantoaxial state segment, and you need atlantoaxial stabilization. So whether the extra water is present inside the spine, inside the spinal medulla, or outside the medullary state segment, whether outside the medulla and in the extracerebellar space, they are all indicators of one problem, and that problem is atlantoaxial instability. I also wrote this article with my daughter on external syringomalia and benign foramen magnum tumors. When there is a benign tumor at the foramen magnum over a long period of time, they get extra water is collected in the spinal cord and brain, and they are protective and they are suggestive of chronicity of the issue. So these kind of short head, short neck, short spine are all secondary. They are all hallmarks of basilar invagination. They all indicate atlantoaxial instability. They all indicate the need for stabilization. And you can give beautiful king-like smile to these children. And there is no question about it. Another fantastic issue is about dorsal kyphoscoliosis in this age group, in adolescent grade age group, whether they are present with Chiari or whether they are present with syringe. This short spine is related to dorsal kyphoscoliosis. The problem is at the craniovertebral junction. You do atlantoaxial fixation, the whole spine can become straight, and the entire symptom complex of the patient can disappear in the evening of operation. I think we cannot ignore this issue of central instability in this situation. So we should try to understand central or axial instability, which is an emerging concept. And when you see a situation like bifid, when you see a situation like syringomalia, even when there is no compression at the craniovertebral junction, there is no point in touching the spinal cord. There is no point in doing any other thing but atlantoaxial fixation. And there is only one thing that you will get is a beautiful smile on the face of the patient. Now I turn the corner to another fantastic clinical entity called degeneration. If you read the literature, nobody in the world talks of degeneration of craniovertebral junction. Nobody talks. So if you really ask me, I will say degenerative issues in the atlantoaxial joint are the most common form of spinal degeneration. C5, C6, C4, 5 degeneration, which we always like to look at and see, are less frequent than C1, C2 instability. More the mobility, more the possibility of instability, and more the possibility of spinal degeneration. So this article we wrote in the year 2010, where we discussed our experience. Now we have got several patients with spinal degeneration. And we particularly, when we talk in the parlance of our people becoming old, they become 80, 90, so many years old, and they will certainly get instability of the craniovertebral junction. Now, my dear young friends, I want you to look at this slide very carefully. I want you to see the presence of this buckling posterior longitudinal ligament. I want you to see reduction in the joint space. I want you to see these osteophytes. These are not primary issues. These are not dangerous. They are protective and they are reversible. They are secondary to vertical spinal instability. There is buckling is secondary. Osteophytes are secondary. Reduction in the joint space is secondary. They are protective. What is their indicators of one problem, and that problem is atlantoaxial instability, and stabilization is the treatment. Ossification of the apical ligament, presence of osteophytes here, presence of osteophytes here are not, there is no point in decompression. They are secondary, they are indicators, and this indication we should not ignore. They indicate an unstable atlantoaxial joint, and we have to do atlantoaxial stabilization. The other issue which we discussed and which was quite controversial once upon a time, that this kind of retroodontoid pseudotumor, the whole world was doing transoral decompression or lateral decompression or endoscopic decompression. Still many people do. But we had talked about this, that this retroodontoid pseudotumor is like osteophyte. They indicate an unstable atlantoaxial joint, and they indicate that atlantoaxial stabilization should be done, and this will disappear spontaneously. So this article I published in Japanese journal for the first time in the literature in 2004, and many people in the world like to do atlantoaxial fixation now for this clinical entity. Vertical facetal instability. You see, when we talk of spinal degeneration, we talk of disc, we talk of osteophytes, we talk of posterior longitudinal ligament, we talk of ligamentum flavum, but we never talk of instability, which is primary. My feeling is disc is never the problem. Ligaments are never the issue. Muscle weakness is the issue. Facets are the strongest point of the spinal segment. Vertebral body, spinous process, transverse process, they are not as strong as facets. The whole weight bearing is on the facet. Facets form the fulcrum of all spinal movements. Facetal stabilization is the issue because instability is first manifested at the facets. All the muscles of the spine are focused on the facets. There is no focus of any muscles on the vertebral body on the disc because all the muscles are located in the extensor compartment from the transverse process focused on the facet, from the lamina on the facet, from the transverse process on the facet. So this is the fulcrum. So like I talked about listhesis of C1 over C2 for basilar invagination in the year 2000. Now I say that degeneration is the listhesis of the facets of the subaxial spine is the primary source of spinal degeneration. It is that all the changes are secondary. All the so-called pathological features that we are used to understanding are secondary. So is instability the nodal point of pathogenesis of both spinal spondylotic disease or OPLL? My answer is absolute. So first, I want to briefly discuss about retroodontoid pseudotumor, pannus, or cyst. This kind of rheumatoid pannus in rheumatoid disease, the whole world was doing transoral decompression for this. We introduced that you do fixation, the pannus can disappear in the immediate postoperative period. This is due to vertical collapse or vertical instability. And this is not a problem. This is not a pathology. This is due to buckling of the ligament, which will disappear as soon as you do fixation or eventually. This kind of retroodontoid cyst, you do fixation, there can be a possibility of immediate disappearance or in few months it will disappear. There is no need to do any primary treatment to these kind of cysts. Retroodontoid pseudotumor pannus, this paper I have published and you see the more details about what I mean to say. Now, my dear friends, I want you to carefully see this slide. Carefully see this slide. Reduction in the body, this interbody space, reduction in the disc space, which is considered to be the generator of spinal spondylotic disease. Buckling or bulging of these discs, of the cervical spine, osteophyte formation, they are not primary processes. They are due to vertical spinal instability. They are all secondary. All these features are secondary. All these features are protective, and all these features are reversible. So this concept is huge, and it can change our spine surgery. You try to understand this concept. In the year about 15 years ago, for spinal degeneration, osteophyte formation, we used to do facetal distraction, distract the facet, and you see the posterior longitudinal ligament reduces, compression reduces, the disc space increases in size, and we introduce, and there is no need for any kind of decompression. So it, in my mind, it completely changed the concept of spinal degeneration from decompression to realignment and stabilization. So during the 15 years ago, we did many cases like this. You see ligamentum flavum buckling, posterior longitudinal ligament buckling, you do, and this is immediate postoperative period, multi-segmental facetal distraction. And this is a philosophical, phenomenal kind of treatment. There is no question. And the most importantly, you identify the correct segment of instability and stabilize, and you see a clinical magic that you have never seen by decompression. You see there is no, and radiological, you see the complete change, increase in the disc space, ligamentum flavum is okay now, this bulge has gone, and there is a complete change. So we have done for single level, for multiple level, for radiculopathy, for myelopathy, this kind of facetal distraction. The aim is not decompression. The issue is instability. The aim is stabilization and achievement of arthrodesis of affected segments. So we have gotten several patients with this kind of treatment we have done, and you see the magical clinical and radiological result that we have reported, and you can see my reports on this subject. So this was the beginning of a new concept in spinal degeneration, and this was published as cover page of Journal of Neurosurgery in 2011. So this introduced a new hypothesis that decompression is not the issue, stabilization is the issue. We introduced these kind of spaces, and we have several patients we have done at that time. Same concept, lumbar canal stenosis is due to multi-segmental vertical spinal instability. There is listhesis of the facet, you introduce these facetal distractor spaces, and we published this article about 10-12 years ago with this kind of treatment without any kind of decompression. So decompression of the compressed and deformed neural structure has been the basis of treatment of spinal degeneration for several decades. Now I introduce my current concept, and which is no question in my mind, an absolute revolution in the field of spinal surgery and degenerative spine. Only fixation, not even distraction, only fixation, which we introduced in the year 2013. And more recently, I published my series in the year 2020 about so many cases. If you read the title, muscle weakness related instability is the cause of cervical spinal degeneration, and spinal stabilization is the treatment. You see, there is no mention about discoidectomy, osteophyte removal, or laminectomy or corpectomy. Only stabilization is the treatment. So this is you see here, multi-segmental compression, and after 1.5 years, the whole compression is gone. There is no decompression, only stabilization and arthrodesis using Camillus technique, transarticular fixation, which is very safe, simple, and very solid. So there is a possibility of looking at degenerative spinal myelopathy with a different eye, with a different vision, and with a different treatment protocol, which can be a complete change from what we are doing. Instability is the cause of symptoms, and stabilization is the treatment. And I've got several articles on this subject, which I wish that many of you young people must read. Most important issue is when we talk of instability of the spine, we have to have some criteria and features which direct us. What are the unstable segments? Which segments need to be stabilized? Now you see this image where there is a two-segmental quite a significant compression, the whole world will definitely either do corpectomy or discoidectomy and all those kind of things. I have done only fixation of 4 levels and arthrodesis, and you see the whole thing has gone and disappeared. And you have to just, I have to tell you, remarkable clinical improvement, which you have never imagined with corpectomies and all those things. Now I want to talk about central atlantoaxial instability in degenerative cervical myelopathy. When we talk of cervical myelopathy, we talk only of C5, C6, C7. We talk of compression. We don't talk of instability. We don't talk of atlantoaxial instability because there is no compression. But if you see the facetal malalignment, even if you do not see facetal malalignment, atlantoaxial instability is a very frequent and neglected association of multi-segmental spinal degeneration. And you have to include atlantoaxial stabilization in your fixation construct. And there is no need for any kind of decompression. And I have to tell you, a magical treatment. You just cannot say there is no compression, so I don't do any kind of, don't say that there is compression and I do decompression. These are manifestations of vertical spinal instability. These are manifestations and secondary results of instability. They are protective. And you need to identify the unstable segments, include atlantoaxial joint in the fixation construct. And when their patient is having severe myelopathy, patient is coming on a wheelchair, on a trolley, many of these, more often than not, they have atlantoaxial instability, and multi-segmental spinal fixation is the treatment that includes atlantoaxial stabilization. And if you ignore this atlantoaxial instability, there is no question in my mind that you will not get a very fascinating result, and you will blame your instruments, you will blame the corpectomy, you will blame your drill, and you will blame everything else. But you should, if you ignore atlantoaxial instability, there is no other person to be blamed other than you yourself. Lumbar canal stenosis. So this was an article published in Neurosurgical Focus. You read the title. Lumbar canal stenosis, analyzing the role of stabilization and futility of decompression. So there is no need for decompression in a lumbar canal stenosis. So this is quite a controversial like statement, but this is an absolute truth. So when there are multi-segmental disc bulges, canal stenosis is the outcome on radiology. But what we do not see is the multi-segmental instability. What is required is multi-segmental stabilization. Old age leads to multiple segments muscle weakness, and multiple segments back pain and claudication pain and radiating pain are all due to unstable spine. Stabilization is the treatment. What happens to osteophytes when you are doing multi-segmental stabilization, only stabilization? So we wrote this article, and a beautiful, you see, don't ignore these concepts. My dear friends, I know you will have confusion or you will have some different views, but I suggest to you, don't ignore these radical and revolutionary concepts, which have a great potential to completely change the field. Multi-segmental osteophytes, you see all the osteophytes have disappeared after a period of time. There is no corpectomy, there is no laminectomy, only stabilization. And we have got several hundred patients like this. More important than anything is an absolute magical clinical outcome in these cases. So we should not call stenosis. This is a wrong term. We should call multi-segmental instability. What about deformities of the spine? Deformities. When you see deformity, you start talking of decompression. You start talking of corpectomy and decompression. But deformity is secondary to unstable segments. So you find out which segment is unstable. Here it is clear that there is atlantoaxial instability. You do atlantoaxial stabilization. Here you see there is atlantoaxial plus central atlantoaxial instability. So you stabilize the unstable segments, identify the unstable segments, and you see an absolute clinical magic. So this was published in World Neurosurgery. I wish that you please read this article and identify what are the indicators, what are the unstable spinal segments that need stabilization, and how to stabilize them. You see there is an external syringomelia, there is some kind of kyphosis. We have done multi-segmental stabilization in this patient. And you see the clinical outcome. This person was not lifting the hand. In the immediate postoperative period, both hands are up. The shoulder was down and there is shoulder is up. So there is a possibility of a revolution in the treatment. So there is no need for decompression. Another fantastic revolutionary clinical situation I am giving you, prolapsed disc or extruded disc. So when we talk of disc, we talk of microdiscectomy or endoscopic discectomy and all those things. So my concept is disc herniation is secondary to instability, or disc herniation causes instability. When you lift heavy weight and the disc herniation, it is herniated because of unstable spine. You wear a belt, the pain will go. You wear a collar, the pain will go. What is required is stabilization. There is no need for removal of the discs. The whole world will come and do discoidectomy or ACDF and all those things. My vision is completely clear. You stabilize, you identify the unstable segment, you stabilize and the disc will disappear. More important than that, anything else, the patient will, in the evening of operation, will have no symptoms, no pain, and no remarkable improvement. So this was my series, which we published in World Neurosurgery on facetal fixation arthrodesis as a treatment of radiculopathy. And I wish that you please read this article to get more beautiful details. Lumbar disc, yeah, controversial, all right, but there is no question in my mind that there is no need to remove this disc. There is no need to remove this. There is no need to do any kind of decompression. You do stabilization, the disc will disappear. And we have got several patients where we have done fixation without any discoidectomy. And we have published on several occasions as to what the treatment and what is lumbar fusion. Now I come to my last chapter in my presentation today about OPLL, which is very common in Japan. And Professor Izumo is sitting here, and I will like to have his opinion. I am giving you a concept that OPLL is secondary to unstable spine, and only stabilization is the treatment of OPLL. There is no need for decompression. So this kind of OPLL, many people in the world will do corpectomy, and many people will do laminoplasty and things like that. I am saying there is no need for any kind of decompression. You identify the unstable segment and stabilize, and you will get a beautiful clinical outcome that you have never realized with decompression and a very difficult operation of corpectomy in this situation, removal of bone anterior to the spinal cord and all these things. You do this simple, solid, strong, and stable technique of transarticular fixation, and you see a magic. Another fantastic central or axial atlantoaxial instability is an absolutely common association in OPLL, which is completely neglected in the literature. So these multiple articles I have written on this subject, that OPLL is the role of craniovertebral and spinal instability related to OPLL is a very fantastic form of treatment. So when there is OPLL on multiple segments, you identify that there is atlantoaxial instability, whether there is facetal malalignment or not. You do atlantoaxial and subaxial stabilization, and that is the treatment without any doubt for this kind of huge compression. So when these are compression are not primary, they're related to unstable spine. They are not, there is no role for any kind of decompression. Only stabilization is the treatment, and a very fantastic clinical outcome. So atlantoaxial and subaxial spinal, can it revolutionize the treatment of myelopathy related to OPLL? My answer is absolute in affirmative and yes. Last thing which I'm going to talk is about Hirayama disease, which was identified in Japan long ago, but nobody has ever been able to identify what kind of treatment should be given for Hirayama disease. So we identified that central or axial instability and subaxial instability is the cause of Hirayama disease. You have to stabilize the spine, and you have to see a magical form of treatment. So my last few slides is transoral decompression for such issues is not necessary, is negative, is historical. Foramen magnum decompression is not necessary, it is negative, it is going to become historical. Similarly, I am saying that anterior spinal decompression, corpectomy, laminectomy, these kind of decompression will soon find a space in history books. So we have got a long journey in spinal degeneration from only decompression to only fixation. And I hope, my dear friends, you have enjoyed this presentation and you have got some brand new concept which you may adopt or which you may not, but these are my concepts, and I wish you had success in your young careers and progress with keeping your minds supple and movable, not fixed ideas, but be ready for a change. Thank you very much. And Sachin, over to you. Yoko, over to you.
Thank you, Professor Gore. Sachin has to leave for several minutes, so thank you for Professor Gore's lecture, which completely rationalized the concept of the spinal instability. So may I invite comments from Professor Izumo?
Thank you so much, Professor Goel, for an excellent presentation. The point you made regarding craniovertebral junction and spinal surgery were very thought-provoking. I was so impressed with your word. Compression is never primary. Decompression is never the treatment. That is also the case even in the Chiari type 1 malformation. I was so impressed with that word. I have one question. How can we avoid the central instability in a view of preventive medicine? Do you have some recommendation?
Sorry, Professor Gore, you need to unmute yourself.
Hello?
Yes,
Okay.
we can hear you.
Yes, I can hear you.
Yeah, see, the most important thing is, we have human body has a standing position. Our muscles are strong. We need to strengthen our muscles. We need to run. We need to jump. We need to go to the gym, and we have to take care of our body. We need to take care of our muscles. We cannot say we have become old, now our muscles will degenerate. We cannot say, and also injury, sometimes you lift heavy weight and you can injure your spine. And my feeling is craniovertebral junction, lot of it is related to injury of the craniovertebral junction. Like, when you deliver a child from a pregnant lady, you use forceps and you damage the craniovertebral junction at that time. So injury of the craniovertebral junction in muscles is a very important issue. So we have to prevent injury to the muscles and we have to strengthen our muscles. So these are the things that we have to do, and we have to take care of our muscles and body. So if we take care of our body, do not injure our body, you will not get muscle weakness. So that is the concept.
Thank you so much.
Now, what I recommend is let us listen to the next lecture of this young boy on, or if you have any questions, maybe we can answer. I can answer the questions. Yoko, I want your comment.
Yes. Well, thank you very much. So maybe I think we can take some comment from Dr. Alexandra.
Yeah.
Can you hear me? Okay. Thank you very much, Professor Goel. As usually, the brilliant lecture. Your conception, I follow it for many, many years. You develop it, and every next lecture is more and more interesting. So thank you very much. I cannot comment the master's lecture, but I have some questions, practical questions. For example, if I have a patient with the carrier malformations, with the clinically manifesting, with the syrinx, and with no signs of instability at the atlantoaxial instability, for example, tonsils on the level of C2, severe herniation, what would you recommend to do the preventive fixation or just decompress?
There is no need for decompression. That is the issue, my dear. You know, decompression has been done for last several decades. You know, I was also doing decompressions for Chiari and for syringomyelia and all those things. But now my feeling is, after my experience with more than 450 cases with Chiari malformation, I have absolutely no doubt, absolutely there is no confusion in my mind, that if you want to treat this person of Chiari completely, if you want to give this person of Chiari a new life, you have to learn the art of doing atlantoaxial stabilization. You have to learn the art of opening the atlantoaxial joint. You have to learn the art of denuding the cartilage, introducing bone graft in the joint, and then do C1, C2 fixation, solid fixation. If you can do this operation, you are, there is a potential of completely changing the treatment paradigm for this very commonly discussed and commonly seen clinical entity.
Thank you. So you recommend, thank you very much. So you recommend to elevate the space between atlantoaxis in these cases when we
No, I'm not. I'm not saying elevate the space or distract the facet. The issue is instability, and the treatment is stabilization.
I see. Okay.
There is distraction, and all those things are not necessary. Distraction is necessary for basilar invagination.
I see. Yes,
You have to remove the cartilage, introduce bone graft, not for distraction, but for arthrodesis and stabilization.
Okay, thank you. And another question about stabilization of the spine. When we stabilize the segment, we overload the adjacent segment. What is the destiny of the adjacent segment in your practice in long time follow-up?
See, it is very, very, very important, when there is muscle weakness, it cannot be one segment or two segments. It usually is multiple segments. Unless it is a disc herniation. Disc herniation is due to injury of the muscles. So usually we go only by radiological indicators. When we see osteophyte, we think that this is the segment. But there can be segments which are above that segment and below that segment. That has been seen during operation. So my article, I wish that you can read my article. What are the indicators of spinal instability? There are clinical indicators, there are radiological indicators, there are intraoperative indicators. And when those indicators, all of them have to be seen, and even when there is no indication on radiology, you will find that intraoperative, there is instability and you stabilize. So if you carefully notice my cases, I have done, if there is only C2, 2-level osteophytes, I have done 3-level or 4-level fixation. That is on intraoperative observation. I think this intraoperative observation is very crucial and very important to avoid this adjacent segment disease. But it can happen, even then it can happen, adjacent segment, as you know.
Oh, yes. Okay, thank you very much. Thank you.
So Dr. Ben, do you have any question to Professor Goyal?
Yes, I have a question for Professor Goel. And may I ask, Professor Goel, for when you deal with basilar invagination, so beside the fixation, do you need to reduce the invagination first? If you reduce it, how would you reduce it? Can you share some tips for us?
See, there are two things which I mentioned about basilar invagination. One is realignment. So my procedure is, you go from behind, open the joint and distract the facet. So that is my procedure to reduce basilar invagination. But as you have heard me, my current concept is basilar invagination is due to instability of atlantoaxial joint, more than reduction, more than realignment. Solid stabilization is what is necessary, and that is the treatment. Solid stabilization. You have to achieve a very beautiful fixation. And if you can realign, it is okay. But if you cannot realign, it is not bad. But if you do not stabilize it properly, it is not good.
So usually, how would you what method would you try to realign that? And is there some tips for your technique?
Only one method, that you go from behind, open the joint, remove the cartilage, distract the facet, introduce multiple bone graft, and then do fixation. That is my technique, which I described 20 years ago. And many people, even in China, I don't know about Japan, but many people in the world are doing this technique. Those who are now focused in craniovertebral junction. Many people in China, of course, are doing this technique of posterior surgery. Some people in China, of course, are doing anterior decompression and joint releasing and all those kind of things. But many in China are doing. But more important than the technique is the concept that these are not fixed. These are unstable. These are unstable and reducible. And realignment, they are unstable and need stabilize. That concept is important, whether you come from mouth or whether you come from behind or whether you come from lateral. That is not the issue. The issue is, this issue of instability was not recognized 25 years ago, 20 years ago. The only treatment was decompression by mouth or by from behind. So this concept that these are unstable issues, they can be stabilized, has completely changed the treatment concept.
Thank you so much, Professor.
Thank you.
Dr. Chen?
Yes, Professor Go. Yeah, this time you totally changed my my mind, my idea. In the before, I saw spinal neurosurgeons, they just do the decompression operation for Kira deformation. And this time I learned a lot from you. Stabilization is very important, important than decompression. And usually I saw spine orthopedic doctor. They cut the disc, intervertebral disc for those cases. But now you teach us stabilization will resolve this problem. So just like you mentioned, muscle is very important and support our body. And may I ask a question? After operation, when the patients can do the workout to exercise their back muscle and can strong support their spinal after operation?
The most important thing is, if the segment is unstable, you have to stabilize. That is one thing.
Yeah.
And whatever segments are stable, you as soon as you are ready for exercising, as soon as you're, I will say within 2, 3, 4 weeks, you should start exercising. If there is a C5, C6 fixation, if you do not exercise and you just keep your neck straight, you will develop adjacent segment disease, as we were discussing. So as soon as you are ready, you start exercising your muscles, you start exercising your body, and you give stability to your spine. So there is no question. So as soon as you're ready, you start your workouts.
Okay, so as soon as the patient is discharged from hospital and the wound is clean and healed, they can do the exercise for their body stronger, right?
Within 3 weeks, I think you should start your normal life. And maybe in 1 or 2 months, you should start jumping around and, going for exercising.
So you mean no jumping, and if they can do weights to stronger the body.
Yes, you must. Everybody should keep themselves fit, and everybody should keep themselves strong.
Okay.
And if you are strong, you are young. If you are keeping your mind active, you will always remain active. If you think that you are retired and finished, you will be retired and finished. So you should never think that if you are completely alert, doing work, this and that, you will always remain alert. You will never become retired. Similarly, if you think you're old and now you walk slowly and you don't, then of course you will start spinal degeneration and all those things. So the most important thing that we have to do is keep our body fit, keep our mind fit, keep our brain fit, and keep on using the facilities which God has given, and that will keep us healthy and which keep us for a long time.
Okay, I see. Usually, this question is from our patients. They would like to ask their doctor, when can I move like normal people? They usually wear a support device or equipment on waist and the neck. So in your suggestion, this is not good. So they can start recover their body muscle after operation, right?
Yes, yes.
Okay, thank you so much.
Aaron, you raise a hand.
Thank you, Professor Kato. I have a question for Professor Gell. First of all, thank you for this wonderful lecture, and really a lot of ideas will change the practice in this specific field. My question is for the symptoms. Most of the patients, especially the case you present for the lumbar with the huge disc, they present with radiculopathy pain. And with stabilization without decompression, how long it will take for the symptoms to improve? The patient will complain after the surgery that you did the surgery, but I did not benefit from the surgery in the symptom wise.
Okay, now let me explain to you. Let me tell you. So if you have an acute disc herniation, the first thing that you will suggest to your patient is wear a lumbar belt, okay? Lumbar belt or a cervical collar. So this collar, many of the patients will, if you wear a belt and you keep your back straight, there will be no pain. But if you little bit move, a little bit your back moves, or a little bit your neck moves, there will be severe pain. So cervical collar and lumbar external arthrodesis are very well recognized for centuries, this treatment of lumbar disc. And many patients, if you give a belt, they don't even need surgery. So this treatment which I am recommending is like an internal arthrodesis. You go and you fix the segments. There is no possibility of movement. And I have to tell you, you see a magic. There will be as soon as the patient is emerged from anesthesia, all pain and all symptoms are gone. So that is you have to think in a different perspective. And this is a different revolution in the treatment. And of course, people will argue and discuss this for a long time. But a concept I am presenting, and one has to really think in those lines. And I have published quite heavily on these things. And I wish that you please read many of my articles and you get my full concept in a right perspective. But your answer to your question is, the pain will disappear as soon as the patient comes out of anesthesia for good and permanently, which you have never seen by any other kind of treatment. Lumbar canal stenosis, you do multi-segmental stabilization and you see a treatment magic that you have never seen by decompression. Multi-segmental degeneration, you see corpectomies, 2-level corpectomy, 3-level corpectomy. I have described oblique corpectomy, was described by me. I was doing corpectomy for several years. Corpectomy for OPLL, corpectomy for degenerative spine is not an easy operation. And if you read the topmost articles on cervical spine on corpectomy, complications can go more than 50% more for 3 or 4-level corpectomy. You do this operation and you see a magic. You see a magic which you have not seen. So that is the thing. My suggestion to all young people is just go read some of these articles properly. I have given just few sentences as my explanation. These are very big issues in neurosurgery and in spine surgery. They are not one statement answers. They are very big concepts. You must read them properly with, slowly and properly my articles. And if you wish, I will invite you to visit me, spend some time with me, and maybe I can explain to you better. Okay? Sachin, you want to say something?
Yes. I would just want to repeat that. I believe me, all the young neurosurgeons. I personally visited Professor Atul Goyal and seen the way, the philosophy with which he operates. It's really very inspiring, and different thought processes, different ideas, different techniques you learn. So if if you have time, even if it is for 2 days, it is more than enough to get that knowledge from him. So please try to do visit Professor Atul Goyal. May I request Dr. Abida Shah? She's also there. So can you please make some comment, Professor, because you've been associated with Professor Atul Goyal for so long. So anything you want to say, Professor?
I would like to say that I'm the luckiest neurosurgical student in the world to have a teacher like Professor Atul Goyal. I mean, what I have learned from him, what he has taught me is a different kind of neurosurgery. It has opened my mind. And you know what, when they say who is a good teacher, teacher not only teaches, but a teacher stimulates and makes you want to go better, to go beyond. And that is what Professor Goyal does. And I have been witness to this revolution of craniovertebral and spine surgery. I've been part of the journey, and believe me, the results are outstanding and magical. The patient gets a new life, their patient's family gets a new life, and you feel very, very happy when you see the clinical and radiological outcome. I mean, that gives you a kind of satisfaction that you will not get anywhere else, the kind of results that the surgery gives. And I would like all of you to think about this concept and start doing and start performing surgeries using this concept, and you will see the results in your own, with your own eyes. Thank you, sir. Thank you very much, Sachin.
Thank you very much, Dr. Abida. Are there any other? Yeah, I can see Dr. Chen, you have a hand. You want to say something?
Yes, thank you all to teach and answer our question. Certainly, I think of in your opinion, if in your opinion, protrusion of intervertebral disc is the result of unstable vertebral. So we cannot only resolve the result, we should resolve the cause. So you mean stabilization is the principle for the operation. Am I right? I mean, disc, the disc. Usually we just cut the disc for the such patient.
So you think about this, you think about these concepts, and whenever an opportunity, you try to use this concept, and maybe you can change your mind and change your the life of the patient. You think about this. These are, something which is quite different from what is conventional and what is routinely done in the world. So this concept, I have no doubt and no hesitation to say that these are the future. This is the future of spine surgery because of the kind of results I'm getting. So this is you cannot ignore this for sure. There's no question you can ignore this concept, and it will eventually come to it.
Certainly. Thank you very much, Professor. Are there any other questions or doubts from any participants or the panelists? If not, we'll move ahead with our next speaker. And if you have any question, I would request Professor Atul Goyal to be with us. Sure, the next topic, we do need your help, because our next speaker is Dr. Ahmed El Hamari, who's the member of our ACNS YNS team. He is neurosurgeon at King Saud University Medical City, Riyadh, Saudi Arabia. He's closely associated and works with Professor Rimad Kannan, and he's going to talk about tuberculum cell meningioma. So I request Professor Goyal to be with us, and at the end, when he finishes his talk, please share your ideas and your suggestions also about this point. So may I request Dr. Ahmed to please share your screen and start your talk, Dr. Ahmed. Yes, we can see it.
First of all, I would like to thank the organizing committee and a special thanks to the Professor Kato for the numerous educational opportunity, and she's always keeping the young neurosurgery educated, and she's working very hard for the new generation. Also would like to thank the Professor Go for excellent and wonderful lecture. We learn a lot, a new technique, a new concept to be understood by the young neurosurgery. I would like to thank my mentor, Professor Imaduddin Kanaan, for the opportunity of learning and to present today. I will talk about the tuberculosis meningioma briefly, and we will go through the case illustration and steps in the surgery. So as you know, the meningioma is the most common intracranial tumor, accounting for 32% of all brain tumor. And the tuberculosis meningioma represent around 10% of this number. And they mostly present with insidious and progressive visual symptoms, including visual loss, optic nerve atrophy, and visual field defect. And the visual loss can be present in different patterns of unilateral temporal field defect with contralateral choroidopathy is the most common presentation, only occur mainly in 2/3 of the published series. And if the tumor is large enough, it will cause chiasma syndrome, Foster Kennedy syndrome, or some endocrinal abnormality. In terms of radiological features, typically meningioma appear as a dural base masses, iso-intense in T1 and hypo to hyper in T2 with enhancement. And the tuberculosis meningioma is identical radiologically and pathologically with other meningioma. The only difference is the location, and it's an important location. That's why we will understand the surgical anatomy, and we'll go through the surgical anatomy a little bit, because it's important to rehearsal the surgery before you go to the operating room. This will increase the chances of you get things right, and you reduce the outcome, you reduce the complication and improve the outcome. So cilia turcica is bounded anterior by the tuberculum cilia and posterior by the dorsum cilia. And anterior to the tuberculum cilia lie the planum sphenoidal, and between these two areas is the chiasmatic sulcus, which is important structure to identify because the optic canal and optic nerve lie lateral to that. And optic chiasm lie posterior and superior to the sulcus. The tuberculum cilia arise primarily from the dura covering the tuberculum cilia and chiasmatic sulcus, and involve the dura and the limbus sphenoidal anteriorly or diaphragmatic cilia posteriorly. And it's important to identify this area because the blood supply to the tuberculum cilia typically from the posterior ethmoidal artery. And when the tumor is larger size, it will get supply from the anterior communicating artery and sometimes from the anterior cerebral artery. There is a multiple description for the tuberculosis meningioma. Congo and his colleagues, they describe three categories of this lesion. First category that originate from the upper leaf of diaphragma cilia anterior to the pituitary stalk. Second category is posterior to the pituitary stalk, and the type C originate from the inferior leaf of the diaphragmatic cilia. And there is multiple classification. The aim of this classification is to understand the outcome of the surgical procedure and to know the amount of resection and the visual abnormality that can happen due to the tumor itself. One of these classifications is talking about the tumor size, optic canal invasion, vascular encasement, brain invasion, and previous surgery with previous radiation, and give point to each category, and the sum of this point will give you the result. The other classification, which is kind of simple one by Michael McDermott, proposed this grading and focus on 3 points: the tumor size and optic nerve involvement, and arterial involvement. And this to give you the idea about the visual outcome of these cases. When we talk about surgical approach to tuberculosis meningioma, there is a variety of approach, either transcranial or transnasal approach. And to choose a specific approach, it will help you to get the patient the best outcome it can achieve, and to reduce the comorbidity and reduce the mortality. And there is a spectrum of surgical approach has been described for meningioma of tuberculosis. Orbitocranial, supraorbital, bifrontal, pterional, modified OSI craniotomy, and there is minimal invasive procedure like transnasal approaches. And to select with this variety of approaches, you can select one of them based on the patient itself and based on the pathology itself. And this will give you a better outcome, safer procedure, shorter to the target, and excellent exposure and excellent outcome. And it will give you also the better management of complication and to give you the optimal reconstruction and repair. These are the steps that we will we did, and I learned it from my mentor, Dr. Kanaan, in such cases, is selecting the right approach for the specific patient and right position. It's very important in these cases. Optimal craniotomy, drilling sphenoid wing anterior and clinoid process, opening the Sylvian fissure, releasing CSF to decrease the retraction on the brain, deroofing the optic nerve and decompression the optic nerve earlier, devascularize the tumor, decompress the tumor, and dissect the capsules from the arachnoid around the tumor. We'll go with cases. This is a 22-year-old female patient. She is not known to have any medical illness. She presents with deterioration in her vision in right eye. It started 2 months prior to admission in our services. So we discussed the patient, the benefit and outcome of the surgery, and we discussed the complication, and we sit before the surgeon and rehearse about the surgery. And you can see in the image here is the position. Using the right position and positioning the patient appropriately for this craniotomy, it will help you with using gravity, venous drainage, relaxing during the surgery, and achieve a better control of the tumor and a better outcome, and avoid an unnecessarily exposure of neural tissue. This is the craniotomy site, and one of the important steps is drilling the sphenoid wing, and if needed, anterior clinoid process. With this drilling, it will minimize the brain retraction, and it will give you an excellent corridor for the next step of the surgery. After that, opening the Sylvian fissure, we are using a needle tip to open the Sylvian fissure, following by micro scissor to drain CSF and to reduce the pressure intracranially and open more space, so manipulating around it will be easier. One of the important steps is deroofing the optic nerve, and it can be done intracranially or extracranially. We are doing in this case using a sickle knife and opening the dura above the optic canal, and using a high-speed drill to decompress the nerve. And it's important before you tackle the tumor, because the nerve is already congested and compressed. Any manipulation of the tumor, it will lead to further damage to the nerve. And you can see here in the picture the pre and post decompression. After that, we identify the area. We're going to dissect the tumor, and we start devascularizing the tumor, which will help you to decrease the bleeding and decrease the time of the surgery, making the surgery is easier. And to be careful, because the area is full with important structure, and some of the perforator in that area will lead to deficit clinically, postoperatively, if injured. After devascularizing, we always advise to utilize the operative facility, neuronavigation, endoscopes. We are using here the Doppler to identify the major fissures and to avoid injury to those fissures. After that, decompress the tumor centrally, and it will shrink the amount, and it will make it easier to go around the tumor and dissect around the tumor. And we can see here the tumor is removing. We remove the tumor, and piece by piece, with decreased amount of retraction as possible, maintaining the perforators, maintaining the arachnoid. And it's very important to keep the arachnoid as much as it will facilitate the dissection of the tumor if the arachnoid is kept intact. And this is the post-operative imaging showing a complete resection. And in this case, we use a unilateral approach. In the other case, which is 37 years, also present with headache and deterioration of vision of the left eye, we elected to proceed with right terional approach and resection of tuberculous meningioma and left optic nerve decompression following the same steps. And we can see this is a post-operative image, and we utilize the endoscopic during the surgery, and which will help in better visualization, especially with the scoped endoscope. So it will to have a look if there is a hidden residual of the tumor, and you can see the intact arachnoid and structure around. This is the steps again for the summary, and thank you very much for allowing me to participate in this presentation.
Thank you very much, Dr. Ahmed Lamari, for that wonderful and brief presentation. I would request Professor Izumo to make a few comments about Dr. Ahmed Lamari's presentation. Professor Izumo.
Yes, thank you so much, Dr. Lamari, for educational review and sharing the beautiful operative video. But I recommend you not to use cottonoid during the drilling of optic canal, because once bug grabs the cottonoid, that leading to injury of surrounding vital structures like optic nerve or brain or ICA, that leading to devastating complications. So again, I recommend you not to use a cottonoid during the drilling of optic canal.
Thank you, Professor.
Thank you very much, Professor. That's definitely a very important point and technical step while operating on the tuberculous meningioma. I would request Professor Alexander Wozniak, President of the Ukrainian Society of Neurosurgery, please make a few comments about Dr. Ahmed's talk. Any suggestion you want to make, Professor?
Thank you, Dr. Alamari. Thank you very much for good presentation, for very good video. I have some comments concerning this topic. I have some experience with this those tumors. The first question in tuberculum cell is the definition of the tumor. So my option is if a tumor involves the clinoid process, it's not a tuberculum cell meningioma. Tuberculum cell meningioma is located in between optic nerves always. It's tuberculum. Once it moves laterally, it invades the planum sphenoidale. It's not a tuberculum cell per se. So it's absolutely different tumor. The another feature of those tumors, the visual loss is almost always asymmetrical. It means that these are not the tumors of the midline. They are always shifted to one of the optic nerves. Very, very rare you will see the symmetrical visual loss, because this asymmetry predispose the side of craniotomy for me. I always operate from the side of better vision, because the syncope of tumor and optic nerves creates a corridor, a window for very good exposure of attachment point of the tumor, for exposure the opposite optic canal from behind the optic nerve. You can go under the optic nerve and remove the tumor from the canal. Also, you can visualize the opposite internal carotids, posterior communicating, and brainstem. That's it. So in my practice, I always use the contralateral approach. Concerning the drilling of clinoid, you told us that the main vascularization of those tumors come from ethmoid arteries. These are the arteries of the midline. So I do not see any sense to remove the clinoid in classical tuberculous cell meningioma. So in case when we operate the huge meningioma, which invade the clinoid, the ethmoid bone, goes to the diaphragm, yes, that's the case. That's a situation when we must perform the big terminal craniotomy, remove all the bone. But in cases of classic meningioma, I do not perform the extradural stage. I use the frontolateral supraorbital small approach, sometimes with the eyebrow incision only. It's quite enough. But I published an article in Neurosurgical Review dedicated to this pathology. You may see, so it's very well illustrated. What else? And I think that's all. And that's all. So that is my comment.
Thank you very much, Professor. I appreciate it.
Thank you.
Thank you very much, Professor Bosniak. Now, may I request Professor Atul Goyal to tell us a little more about tuberculous cell meningioma and comment about Dr. Ahmed Ansari's presentation.
That was a very good presentation, and I send you my best wishes. And I look forward to many more presentations from you. And you know what most important thing I liked about you is your confidence and your, you believe in what you are saying. So that is very important. As far as tuberculum cell meningiomas are concerned, as we have just heard, they may be not just on the tuberculum celli, they may be on planum sphenoidal, they may go behind on the diaphragm celli, they may go lateral to the anterior clinoid process. So there can be a wider attachment. So these are basically called tuberculum celli meningiomas or supracellular meningiomas. So the terminology may be used here and there. The other thing is, you see, these tumors are quite common. These meningiomas are quite common. And I had done a classification of these tumors on the basis of radiology. So like if you have a meningioma where there is a calcification within the tumor, it becomes a little bit more difficult tumor to operate. Suppose the tumor has extensive edema around the tumor, which is less common, but when it is present, it is little bit difficult to operate. The other classification is on the basis of arterial encasement, when the anterior cerebral artery complex, when the internal carotid artery are encased by the tumor. So these features make the surgery different. The other very important thing is the clinical features. So extent of visual deficit. Suppose a patient has complete blindness, and a tumor with complete blindness and tumor with no visual deficit. The tumor with no visual deficit is much easier to operate. Tumor with blindness and are usually firm and they are hard. and they extend into the optic canal. So extent of visual deficit is a very important parameter when we are trying to understand these tumors for surgery. The other thing is the consistency of the tumor more than vascularity of the tumor is an important issue in tuberculum cell meningiomas. The other thing is if these tumors are present in a young girl, in a pregnant person, they are more difficult tumors to operate. When the tumors are multiple tumors, suppose there is a tuberculum cell meningioma associated with another convexity meningioma, they become much more easier to operate. Regarding, when we are operating on tuberculum cell meningiomas, the steps were very beautifully illustrated earlier. The most important thing in tuberculum cell meningioma is preservation of anterior cerebral artery and its perforators. So when we operate on tuberculum cell meningioma, first we dissect from the base, debulk the tumor, and our entire concentration is on the perforators of anterior cerebral artery. Because, from a very beautiful outcome, if you damage one single perforator and you have to coagulate that perforator, you can have a very big morbidity at hand. So all the perforators from the anterior cerebral artery, from the anterior communicating artery have to be necessarily preserved. So my feeling is learn the art of breaking the tumor, learn the art of demolishing the tumor without much coagulation. Devascularize the tumor from the base, debulk the tumor, then dissect from the arachnoid plane, preserve the anterior cerebral artery, preserve each and every perforator. Then, going into the optic canal, whether it is tumor is going, identify the tumor. You see, these are very important steps of surgery. And if you ask me what is the number one important step is that you cannot damage one perforator of anterior cerebral artery because you can create a disaster. So our entire focus of surgery has to be one. Like when we are operating on acoustic tumor, our focus is facial. When we are operating on tuberculum cell meningioma, our focus is anterior cerebral artery and its perforators. So these tumors are beautiful. You can make visual outcome fantastic. But most important is learn the art of breaking and demolishing the tumor without much coagulation. So those are the points which I would like to discuss, Sachin.
Yes, definitely, Professor. Dr. Amit, you want to make any comment to that?
Thank you very much. Thank you, Professor Gold, for important comments. And I would like to thank all the panelists for their contribution. Really, I'm grateful and honored to present with such big names from all over the world. I really appreciate the opportunity, and I extend my thanks to Professor Katu and all the organizing committee.
Thank you, Dr. Amit. Are there any questions or doubt from any young panelists? Dr. Asil, are you there?
Yes, I'm there.
Yes. Dr. Asil is our YNS member from Jordan. Dr. Asil, you want to make any comment about tuberculum cell meningioma, or you have any doubt for Professor Atul Goel?
First of all, I'm happy to have joined you, even though I joined a little bit late. I was working, but the part that I saw was very interesting. Thank you, Dr. Ahmed, for your lecture. And I wanted to ask about, you said that you had you had a right-sided meningioma or a left-sided meningioma, and you went from the contralateral side. Is that correct?
That's correct. In one of the cases, we choose the contralateral approach.
Yeah, because sometimes they would choose the ipsilateral side for maybe maximal decompression of the optic canal. So I was wondering what's your comment on that?
Yeah, the important point for choosing the contralateral approach is tailored to the patient. The right eye is, the vision in the right eye is preserved, and we want to see the optic nerve early and protect it, and to decompress the other side before tackling the tumor. and it's non-dominant hemisphere. So we don't want to manipulate a lot with the dominant hemisphere.
Yes, yes. Thank you.
Thank you.
Thank you. Thank you very much, Dr. Asil, for participating. Ben, you have a hand, you want to ask anything?
Yes, hello, Professor Ahmed. I'm Dr. Ben from Hong Kong. So again, I agree with Professor Goh. You're very confident and your operative video is quite nice. I can see that you use endoscope during your open surgery. Have you have experience in using the endoscopic endolaser surgery for the tuberculum septum and angioma? Because for my center, we have some experience on it, and I find that the result is quite good because we can first of all could firstly devascularize the tumor. Another thing is that we could decompress the optic nerve quite early. So there are some literature which suggests that early decompression of the optic nerve could result with a better postoperative outcome. So I would like to get some review on your experience on that.
Thank you. Usually when we do the endoscopic approach, it will be a multidisciplinary team, ENT and neurosurgery, especially with large tuberculum septum meningioma. Most likely we need to do a reconstruction, and depend on the tumor itself. Sometimes if it's extended laterally, it will be more difficult to do it with endoscope. And it will be also difficult to tackle the tumor that's going to the optic canal. So it's depend on in the case itself. We do both transcranial and transnasal approaches.
May I ask how would you cooperate with your ENT colleagues for the repair of after doing the extended endoscopic approach?
Usually, our colleagues in ENT they prepare nasal flap to cover the area, and sometimes we use artificial dura. After we finish, we put the artificial dura. Then we, with the help of our colleagues, they do reconstruction with nasal flap.
Thank you so much.
Thank you. I think that was the same question which was there in the chat box about how to reconstruct the base when you're doing the endoscopic excision. So Dr. Ahmed has already answered that. Are there any other questions or a doubt from the panelists or from the if not, then I would request Professor Izumo to make a few final comments about the webinar and about the presentations of both the speakers and some few words for encouragement for young neurosurgeons.
Thank you. Thank you all presentators and commentators for your dedication. I would like to conclude this webinar by thanking all the presentators and all of those who commented and made this webinar an interesting one. Thank you.
Thank you very much.
Thank you. Thank you very much, Professor. Request Professor Alexander Wozniak to say a few words at the end. Please, Professor Alexander.
I want to say thank you, everybody. Thank you for very interesting webinar, and thank you for invitation. And want to pass all my best wishes to everybody, and see you next time. Thank you.
Thank you very much, Professor. Unfortunately, our second discussant, Professor Fawad, could not join us. I had contacted one of his junior neurosurgeon, but I think he's busy in some surgery, so he's not able to join. I would request Professor Atul Goyal to say a few words at the end for encouraging all of us. Professor Atul Goyal.
So thank you, Sachin, and I compliment you on organization of and continued hard work apart from that meeting that you conducted and organized of ACNS, which was multi-speaker symposium. You have continued your dedication towards the cause of education and towards what Dr. Yoko Kato has instructed you, and you have taken the baton ahead, and my best wishes to you. And more importantly, my message to young neurosurgeons who are watching this show is that we have to continue our love and affection towards a great subject of neurosurgery. Neurosurgery is difficult, neurosurgery is complex, but neurosurgery is a life giver. If we learn this properly, you can give new life. On the other hand, if you don't learn, you can create a very bad complication. So you have to learn the subject properly, you have to learn anatomy, and you have to dedicate your life. I don't call neurosurgery as a profession. Profession is when you go for work, get money, and make living. Neurosurgery is life. Neurosurgery is complete dedication. Neurosurgery is a lifestyle. You know, you have to mold your thing, have affection for the operation theater, love the smell of operation theater, love how if you can operate yourself, that is fine. But if you are not able to operate, you watch others operate, watch others making mistake, and see how you can do differently. And also you should not underestimate a young mind. You see, a supple young mind can produce new beautiful inventions. What you, if you have a new idea, if you think something different you have discovered during your work, you immediately try to publish it. At the age of 27, I published C1, C2 fixation, which is now, many of you might know that it is quite a popular technique at the age of 27. So you cannot say that young people cannot produce, young people cannot have a new idea, young people cannot have different idea. And you should keep your mind supple. You should not go by whatever is established, okay, that you think differently. You think whatever is the best for the patient. If you think whatever is the best of the patient, you will certainly land with new ideas and new concepts. My best wishes to all of you. My best wishes to continue to love this subject and grow in this subject. And more important is, patient is our, he is what we are meant for. Look for the patient, work for the patient, and think about the patient. My best wishes to all of you.
Thank you. Thank you very much, Professor Atul Goyal. I think Professor Fawad Firdad has joined. Professor Fawad, are you there?
Hello, salam alaikum.
Yes, Professor, you're audible.
Hello. Konnichiwa. Greetings to all. Thank you very much. And also, thank you for you, Professor Kato and Professor Atul Goyal. It's nice to see you all. And this very excellent webinar. Unfortunately, I joined a bit later, and I will see it later, the recording as well. And as Professor Goyal told, that's this is a big and very interesting discipline in medicine, especially in neurosurgery and surgery. And but as you know, I told that in Afghanistan it's the basic and the like classic stages. And we would like to draw your attention for skills, knowledge, and also the equipment, and also the consumable material, especially for a scale. We are looking for trainings, scholarships, fellowships, and we like to have to follow your steps for our future generation. And because of war in Afghanistan and an unstable situation, no one, even governments, invest in the health, especially in neurosurgery. And we would like and draw your attention to help Afghanistan and Afghanistan people. Our people are very poor, and it's situated in low and middle income countries. And maybe someday we follow your steps for the future. Thank you.
Thank you very much, Sir Pawar. I think we've come to the end, so I'd request Professor Yoko Kato to say a final closing remark, and then I'll make announcement of our next webinar. Professor Yoko Kato, you are muted, Professor. You'll have to unmute yourself.
Thank you very much for both the speakers, especially the Attorney Goyle. He is, of course, one of the best neurosurgeon in the world, but he is very philosophical, the teacher. Always his lecture associated with the philosophy. It's very important to learn from him. So he devoted his life for the patient, only for the patient. So I think it's very important as a good neurosurgeon. So always think about patient, the results in the future. And I wish the Goyle, maybe the more and more you accumulate your cases, and let us know the hint and the point for that, especially the YNS. Thank you very much. And also Dr. Ahmed, thank you very much. Even your age, I think you showed us very nice presentation. So in Japan, it's more and more less invasive, especially the pure endoscopic procedure. Already Dr. Izumo, he mentioned. I think maybe in your country, I think in your area, I think in the future, maybe such the pure endoscopic procedure will be getting more popular, I think. Anyway, thank you very much. So please go for it. And also, Izumo Sensei, thank you very much, because Japan is just holiday time. So he loves a dog. So we can see his dog. Besides, he is holding his dog during the lecture. So actually speaking, he is a very good vascular neurosurgeon. He made a comment for the tumor, the lectures. Izumo Sensei, thank you very much for your time. And also Professor Alexander, maybe some are very severe the time every day. I think I understood your situation, but from the vast experience, you gave us the good comment, and also some question, and also some encouragement for the YNS. So please bring your YNS to our webinar, please. If they can have time, I think. Please continue to join our conference, please.
With pleasure. Thank you.
Thanks so much. Even the 3 minutes, we are so happy to see your face. Maybe you are in the OR, I think. Just finish your case. Thank you very much, even your hectic time. So I think all the YNS of the Asian, that we are study and learn the more and more in the future, I think, so we can collaborate each other, I think. Then we can stimulate and encourage in the future. Yes, thank you very much. And Dr. Sway, thank you very much. Dr. Sway? Asil, are you there?
Dr. Asil, are you there?
Yes, I'm there.
Yeah. So best regard to your father.
Thank you, Professor. Thank you.
Thanks
My
so much.
pleasure.
Thanks.
Thank you.
Good question. And Ben, thank you very much. And Dr. Chen from Shanghai, thank you so much. And of course, Professor Sachin, he is the big boss of the YNS committee. Thank you very much. And also the behind our webinar, always look the new, is supported us a lot. Thank you so much. So I give you back to the Sachin.
Thank you, Professor.
Thank you. Thank you very much. Yes.
Thank you, Professor.
Thank you very much.
So nice to meet you again.
Oh, of course, yes.
And thank you, Sachin, and thank you, Dr. Liu, for organizing this webinar. Thank you so much.
Thank you. Sachin, you want to make some announcement? Oh, Amita Shah.
Yes. So the two, yes.
Yeah, please.
So the two announcements. One is our next webinar. So our next webinar.
28th.
I'm not able to share my screen for that. Yeah. Okay. Are you able to see my screen? Yeah. So our next webinar is on 28th August. So that is the 4th Sunday. And we have Professor Tang Chai from China, who's going to talk about brainstem lesions. So how to do an image-guided surgery for the brainstem lesions and what are the safe entry zones. And we have Dr. Sneha Chitra, who is the WIN member, Women in Neurosurgery Committee of the ACNS WIN member, who will be the YNS speaker, and Professor Soichi Oya will be the chairperson for our next webinar. So that is our next webinar. That is one announcement. And again, our ACNS Congress, which is ACNS Congress. So that is about our ACNS official congress, which will be in Shanghai on 28th to 30th October. So there's a special session for all the young neurosurgeons who are willing to travel there, and since COVID is down, and to present in person about their research activities. There's a special session for the young neurosurgeon, an award session. And Professor Bing Zhu is an official organizing president of the Congress, who's given 100 free registration and accommodation for the young neurosurgeon. So whoever is willing to travel, please come and present your work there. And I would request all the participants and all the speakers of today's session, please encourage your young neurosurgeon to send their abstract and participate in the Congress. Thank you very much. Dr. Ben, you want to say anything?
Yeah, I think that's, I don't have particular things to add, but I would again thank you all for this great webinar. And thank you, Professor Kato, and thank you, Dr. Liu and Dr. Sachin, for organizing this. And thank you our speakers today, Professor Goa, who completely share with his rationalizing ideas on the instability. And thank you so much.
Thank you for support, Ben. So thank you very much, everyone. It's the time to wind up, and see you next time.
Thank you.
Thank you.
Thank you.
Bye.
Shukriya.
おやすみなさい。
ありがとうございます。
ありがとうご
あ
ざいます。
りがとうございます。
ありがとうございます。
どうも、失礼し
あ
ます。
りがとうございます。
おや
お
すみなさい。
疲れ様でした。
どうも、井野先生、ありがとうございました。
はい
は
またよろしくお願いします。
い、ごめんなさい
失礼。します。
おやすみなさい。